Welcome to our episode that is titled Regenerative Endodontics. The purpose of this procedure is that when a pulp of a development tooth got necroted and the apex is open, we do a procedure that will induce the continuation of the root formation. So we will talk about how do we do it and the steps of it. 50 years ago, there was a hypothesis that says that the blood clot is the first step in the healing of a damaged dental pulp. Until now, it showed the highest rate of success to do the apexogenesis and to induce the root to apex closure. Although that this blood clot contains different types of stem cells, so when it enters the canal, different types of materials form, like connective tissue, mineralized tissue, cementoblast, and odontoblast-like cells that are all termed under the name islands of mineralized tissue. So there was a deep study of the types of the stem cells and the mesenchymal cells that we can use to guide this process and get the structure inside the pulp to be organized, but we will not go into details because today we use the method of the blood that is induced from the periapical area and it enters to the canal with all of the growing factors and the cells that is present in it, which means that it is not specified or guided. So at the end we get different types of mineralized tissue inside the pulp, but at the end we get the closure of the apex, what is called the apexogenesis. We used to use the calcium hydroxide as an medication, intracanal medication or an apex block, because we found that this type of material releases a bioactive dentin that derives growth factor from the dentinal tubules. But MTA is more preferable to be used than calcium hydroxide because calcium hydroxide by time causes the dentinal bones of the root to get weak. Also using an DTA in 70% as an irrigation solution at the end of the procedure, it showed that it increased the survival of the stem cells and it induced the odontoblastic differentiation because it released the bioactive molecules from the dentin. So they found that it is an important step of doing the apexogenesis procedure. So after that, the scaffold was introduced, which was a matrix that holds in it, whether it is natural or synthetic. It holds in it the cells, the stem cells, and the growth factors that will do the regeneration of the tissue inside the pulp. It is mostly now we use it as a collagen. It includes collagen as a matrix that holds these molecules. Also, we can use the platelet-rich fibrin, the PRF, as that because it is rich in growth factors, and it has a three-dimensional architectural conductive with stem cells proliferation and differentiation. So it has a bioactive mechanism. But what makes its use a bit difficult is that it is required to collect the blood intravenously from children, which makes it a challenging procedure. Also, we know that the third molars are a source of stem cells and growth factors that can be extracted from it and used as a scaffold to be introduced to the canal. These are all options, but now we will talk about the clinical used but in everyday basis. So they're saying that the regeneration of a functional pulp dentin complex relies on the foundation of tissue engineering and can be viewed as a function of the spatially correct delivery of appropriate stem cells and growth factors embedded within a scaffold. Traditionally, an immature tooth with an open apex is treated by apexification, which involves creating an apical barrier to prevent extrusion. This was made by long-term treatment with calcium hydroxide, resulting in the formation of a hard tissue apical barrier. But the disadvantage of the calcium hydroxide is that it produces a potential reduce in the root strength that makes the tooth under danger of getting fractured in 23% of the cases after a year and a half. Although NTA is a good substitute of the calcium hydroxide and decreased the number of appointments and the time to also to the complications were less, but the apexification as a whole it produces a weak tooth. So doing the apexogenesis that we will discuss now is more favorable for the tooth and its prognosis in the long term. We have found that the apexogenesis tooth were able to respond to the vitality tests, and they gained these types. They gained their whole length of root shape. In this case, an 11-year-old female was had a pulp necrotic and apical abscess that was traced here by a 𝐏𝐚𝐭𝐢𝐴, and we found that there was a resorption in the mesial and the distal roots. So the canals were disinfected and medicated with Vita Apex, which is calcium hydroxide. After 4 weeks, the patient was asymptomatic and the sinus tract was healed. Then the tooth was reaccessed and irrigated with 1.5 hypochlorite and ended by 70% EDTA. Then, after we dried the canal, we evoked a bleeding by a pre-curved 25K file. When we wait for 10 minutes until the clot formation is seen, then we place an NTA over this clot. Then we place glass ionomer in the pulp chamber that is followed by composite restoration. After 24 months, the patient was asymptomatic and the root was fully grown. Also, surprisingly, the tooth responded to electrical pulp tester. Also, we can use as an intracanal medication the triple antibiotic paste instead of the Vitabex, which is a mixture of 111 ciprofloxacin, metronidazole, and minocycline to eliminate the bacterial presence in the dentine root canal. This procedure, the apexogenisis, it requires no instrumentation, and the clinician relies on copious irrigation for maximum antimicrobial and tissue dissolution effects. The canals were then medicated for a period that varied from days to several weeks, and then at the second visit, if signs and symptoms of disease has subsided, the medication is removed and the canal is dried. Then an intracanal bleeding is evoked. In most cases, a coronal MTA plug is placed over the blood clot, or we can use a collagen-based internal matrix under the MTA, which is optional, followed by a bonded coronal restoration. So the disinfection protocol is mainly chemical rather than mechanical. In some cases we can use the K file in brush motions on the in the surface of the root from the root canal. This is another case of a 9-year-old male patient that got a necrotic pulp due to trauma, and of these both tooth that got also fractured. And here we see that after the tooth was accessed, he used an irrigation of 5% of sodium hypochlorite, which is considered concentrated. Then he used a mixture of the three antibiotic paste that for 55 days. After the recall, the antibiotic paste was removed by irrigation. The bleeding was established in tooth 9, but not in tooth 8. So the bleeding was in one tooth only. Then a cola coat was placed prior, which is a collagen matrix. It was placed over the blood clot before applying the MTA. Then a composite restoration was applied, and we see after 10 months, I believe that this tooth had the bleeding, and we can see that the development of the apex was more than the other one. This is another tooth, but the cause of the necrotic pulp was due to caries, and we did the same thing: irrigation, then placement of a mixture of the antibiotic paste for 21 days. The time depends on the symptoms. and after that, in the second appointment, we removed the paste, and then the bleeding was evoked. Then we sealed it with MTA and a composite restoration. This is after 6 months of the procedure. When the tooth is in the anterior area, there is a potential of getting a crown discoloration from using the MTA and the monocycline in the antibiotic paste, so we can reduce it or replace the MTA by a biodentin or endosequence material, or we can do the walking bleach technique after we finish the treatment of the tooth. Irrigation with sodium hypochlorite. It is advised that we use 1.5% concentration. Then it is advised that it is activated by ultrasonic tips in low speed, and the tip must not reach the apex. It must be before it in 2 millimeters. The irrigation must be copious but slowly, and our final rinse must be an EDTA, because we said that it is beneficial in controlling, in preserving the stem cells, and in inducing the growth factors that are present in the dentinal tubules. Also, we said that between them there must be a saline to prevent any decrease in their effectiveness, because they produce a precipitate when they are mixed together, the hypochlorite and the EDTA. Also, the hypochlorite, especially when it is 5% in concentration, must not be the final irrigation before we do the bleeding, because this high concentration affects the membrane of the stem cells that will be present in the root, and will decrease the regeneration and the apexogenesis, the procedure as whole. So this is another case. We can see that after the blood was introduced into the canal, the canal must be dried before we do this. Then we wait for 10 minutes until the blood clot is seen, and then we can use this cola coat, or we can we cannot use it. Then we do the MTA and the final restoration. This is the composite restoration. The tooth should not be anesthetized with a local anesthesia that contains a vasoconstrictor, because we need the bleeding to be in its maximum efficiency, and we do not want any vasoconstrictor constriction in this area. The MTA is placed in a thickness of 2 to 3 millimeters, whether it is MTA or endosequence or the biodentin. It should be placed as coronal as possible, leaving enough chamber space for a glass ionomer and composite restoration. The recall usually happens after 12 to 18 months after doing the bleeding step. This is a table that explains the steps. You can screenshot it. The tooth that were treated in this way responded to vitality test in 50% of the cases. This is a tooth that was extracted for an orthodontic treatment. It had an apexogenisis treatment 6 years ago. The pulp tissue was studied under the microscope, and they found that it was an ectopic mineralized tissue, an odontoblast-like cells, and a newly formed tubular dentin. That's it. See you soon. Apexogenesis induces the growth of an immature tooth that lost its pulp vitality by disinfecting the canal and introducing a blood scaffold from the periradicular area to the canal by the following steps. After doing adequate local anesthesia, rubber dam isolation is obtained. The root canal system are accessed and working length is determined using a radiograph with a file that is loosely positioned at 1 millimeter from the root end. The root canal system are slowly irrigated, first with 1.5% sodium hypochlorite for 5 minutes, and then irrigated with saline for another 5 minutes with irrigation needle positioned approximately 1 millimeter from the root end. Canals are dried with paper points. Then calcium hydroxide or an antibiotic paste or solution is delivered to the canal system. Then the access is temporarily restored. The final and the second treatment visit for the regenerative endodontics, which is typically 2 to 4 weeks after the first visit, what we do is a clinician examine is first performed to ensure that there is no moderate to severe sensitivity to palpation and percussion. If such sensitivity is observed or a sinus tract or swelling is noted, then the treatment provided at the first visit is repeated. We use local anesthesia of 3% of mebavican, which has no epinephrine, and a rubber dam isolation is obtained. The root canal systems are accessed. The intracanal medicament is removed with irrigating with 70% EDTA for 5 minutes, and then a final flush with saline for 1 minute is performed. The canals are dried with paper points. Bleeding is induced by rotating a precurved K file size 25 at 2 millimeters past the apical foramen, with the goal of having the whole canal filled with blood at least to the level of the cemento-enamel junction, but preferably coronal to it. Once a blood clot is formed, which is usually after 10 minutes, a pre-measured piece of cola plug is carefully placed on top of the blood clot, preferably above the cemento-enamel junction, to serve as an internal matrix for the placement of approximately 2 millimeters of a biodentin or endosequence root repair material putty. A 3 millimeter layer of glass ionomer layer is flued gently over the bioactive coronal barrier and light cured for 40 seconds. A bonded reinforced composite resin restoration is placed over the glass ionomer. The case needs to be followed up at 3 months, 6 months, and yearly after that for a total of 4 years.